Well, thank you, everybody, for coming and sticking with us through the afternoon. My name is Kevin Callison. I am one of the organizers, along with Celeste, who was up here before, and Mary Olson, who's here, who I want to point out. I'm a faculty member in the Health Policy and Management Department and the Murphy Institute, and I have the pleasure today of introducing our next two guests. But first, I just want to take a second and thank Katie Weaver, who really, none of this would happen if it wasn't for Katie. So Katie's back there and organized all this. Thank you, Katie. And so I've got a long list of accomplishments here to read for our next two speakers. So settle in. This is this continues with our distinguished Tulane alumni. I'll start with Karen DeSalvo. So Dr. DeSalvo is the Chief Health Officer at Google and did both her MD and MPH here at Tulane. Also has a Master in Science and Clinical Epidemiology from the Harvard School of Public Health. Her list of professional accomplishments includes serving as Vice Dean for Community Affairs and Health Policy at the Tulane School of Medicine. She was Commissioner of Health for the City of New Orleans and the National Coordinator for Information Technology and Acting Assistant Secretary for Health at HHS. She has also served as MedPAC Commissioner and a member of the Council. She's a member of the Council of the National Academy of Medicine. Along with Dr. DeSalvo, we have Chip Kahn here today. Chip also got his MPH at the Tulane School of Public Health and Tropical Medicine. Chip is president and CEO of the Federation of American Hospitals, where he has served now for over 20 years, I believe, in that role. Prior to that, Chip spent more than a decade on Capitol Hill, where he served as serving in 2 Senate offices and as the Minority Health Counsel and staff director for the House Ways and Means Committee. He has been named to a lot of lists of influential people in healthcare, including Modern Healthcare's 100 Most Influential People list and Becker's Hospital Review 50 Most Powerful People in Healthcare. And in 2016, Chip won the B'nai B'rith National Healthcare Award, honoring trailblazers in the healthcare industry. So we are very lucky to have both Karen and Chip here with us today, and I will turn it over to you, Chip.
Well, thank you, Kevin. And it's great to be here, but considering and the first 2 panels and the speech by the Assistant Secretary were wonderful, but now for something completely different, the Karen and Chip show. So let's sort of start at 30,000 feet and talk a bit about the trajectory of the current American medical care and healthcare system. I mean, frequently externalities, the advent of Medicare, economic downturns have had major effects on healthcare in America and healthcare delivery. Clearly, the COVID-19 pandemic fits into that. From your perspective, and also maybe most importantly from your work, what do you see as the residual effects of COVID-19 on healthcare, hopefully as we move out of the pandemic itself?
So, Chip, I think that what we're seeing is that the control is moving more and more into the hand of the patients and consumers. And I want to talk about that in a minute. I want to just anchor it a little bit in some of the experiences going back to time in New Orleans, where after a disaster we had here in 2005, we had let's say prior to that, we had a healthcare system that was very anchored in hospitals, and people didn't have health coverage, access to care in their community that was accessible in all the ways that word matters, linguistically, culturally, physically, and that adjustment, re-engineering that we did after Hurricane Katrina in New Orleans was to move from a power structure of people having to take off work, take a couple of buses, whatever, to come into the hospital system to wait in an ER or to wait in a clinic for care, but to actually get it in their neighborhood. And it was a really powerful lesson for me to see how quickly people took that up when we were building out those systems here in New Orleans. There was some friction of, I know where to go at Charity Hospital, and On the other hand, once they knew that they could go someplace in their neighborhood where they actually were known and have continuity of care, you could physically watch them stand up straighter and be more engaged in their own health. And I think that's one way that healthcare has been moving not only into primary care, but to give people more ready access, meet them where they are in community. I think what the pandemic did in a very pronounced way through my lens is accelerate this meeting people where they are, but not just physically, but also virtually. We heard a little bit about this from the last panel, that telehealth went to the Papa Bear size in the pandemic, and it was not just a little bit like before, but really accelerated people starting to say, oh, I can access care and I can do it on my phone, on my laptop, in a way that is easier for me. I don't have to leave my physical space, or I don't have to leave work, but during that time people were cocooning or locked down. And I think a similar story for me is I watch people say, oh, I have an option. You're going to meet me where I am. I don't actually have to physically go into the hospital system or the clinic. I think we're going to, I hope, experience more of that. And I hope the system doesn't contract back to baby bear, but finds a nice middle spot where we can have options available for people that are virtual, asynchronous, and as well as physical, and make that more routine. So that's one thing about the system being respectful of people don't want to have to always come to us in the healthcare system. I think the other big thing about the consumer that is really interesting to me is that we learned how to self-navigate more. I think for a variety of reasons, we had a disconnection from any continuity we might have had, and we also got more tools that we could literally have in our bathroom, like the ability to test ourselves for COVID, or the ability to schedule ourselves for a vaccine at a location that was convenient to us and not have to necessarily go to our primary care doc. And this kind of direct-to-consumer options to augment what they can do for self-care, I expect is going to be something people will continue to demand. I just want to add one more piece, which is, because I was new to Google for the pandemic, I joined just a few weeks before it started. I didn't understand how much people before they become a patient are seeking information and trying to learn, and the volume of that, just to give you all the scale for a platform like Google Search, is hundreds of millions of people a day go to ask questions about their health. 3/4 of people do that, ask questions online before they go into care, and that's a global phenomenon. That's not just a U.S. phenomenon. And in fact, I was telling someone earlier that in the NHS, I don't have data like this for the US, but in the National Health Service in the UK, they've done a survey themselves of their own population, and more women there trust Dr. Google than trust their primary care physician. Now, I'm not saying that that's right or wrong. I'm just saying that's sort of the way, what I think we forget sometimes in medicine is that before they even come to us, they're active, they're learning, they want information, and then we have to make it in medicine or in the healthcare system as easy as possible for them to get quality information, to be able to do the self-care that makes sense, and then to be able to reach us in a way that's not on our terms and our time, but actually in a much more sort of mobile first or community orientation. So we'll see how that all lands. I mean, the power pull of the healthcare system is pretty strong. And we were all talking earlier about the training. All the experience of medicine mostly is, this is what a hospital is, this is the center of the universe for healthcare. And I hope that we don't make patients and consumers have to cede that, I'm gonna say power, because it's really important, I think, that we're sharing that more, giving them more options.
Well, I think what you're describing is another way of looking at the discussion we had earlier. I mean, in a sense, whether it's more primary care or professionals allowed to do more things, the discussions we had earlier really were still in the framework of the current system. And I don't know whether we'll have a paradigm shift here, but if we did, what are some of the approaches tapping into new technologies and other tools you see sort of on the horizon that in some ways would allow us to skip over problems that we were just talking about that we may not be able to solve. We may literally, whether it's for the aged, for seniors, or for others in the healthcare system, may not be enough people to provide the kind of services that people require. I mean, whether it's on the home health side, in nursing homes, or even in the hospital itself. Is technology possibly at least partly a solution?
Definitely. And I'd say, part of this chip is, just want to, one more minute on the consumer, which is and sorry, we call them that, the patient, because they're not always patients, they're people. One more on the people who are not the professionals, they are part of that care team, right? So the more knowledge and information they have about themselves, the more ready they are on their health journey. We say information is a determinant of health. So that's one piece of it, and it definitely, I know, like when my patients showed up, I'm old, so they would show up with a spiral-bound notebook with all their sugars written down in it or all their pressures. Then they had Lotus spreadsheets than Excel. But now it's, a different kind of data. Now it's fed through an API. But it was a different conversation, because they'd say, oh, okay, well, this is my pattern. We could talk about how to adjust their meds predicated on some better data. I think that's a way that I think giving consumers more information and tools in their hands accelerates the conversation. But more specifically, I think the kind of stuff that you're seeing in the field, and certainly that we work on, is where are there capacity and capability gaps that we can help augment with tools like artificial intelligence. And that might be something like I'll go back to the National Health Service, where they have to have 2 reads for a mammogram, 2 radiologist readings, but they have insufficient number of radiologists to read the mammogram, so women can wait 3 months to get the results. So we've been working with the NHS on, okay, well, a human will read one mammogram, will do 1 read, and then AI will do a 2nd read. If they agree, everything goes forward. If they disagree, then a human steps in and is the arbiter, which is actually how they do it now. And so piloting ways that AI can augment that kind of a system. We're doing some work similarly with Northwestern, floating the abnormal mammograms to the top of the queue, so that those are the ones read first by the radiologist, even sometimes before the woman would leave the exam room, or doing that with TV scans in sub-Saharan Africa, or in a place where there's not enough folks that can read the scan. So even outside of the U.S., I think we're already demonstrating, not only Google but others, that you can augment and support care by helping physicians either to do the priority things earlier, to triage people to ophthalmology services where there might be limited services, and or just to augment sort of even the reads of the path or the mammo slide. So that's one way that I think we're going to see, especially in specialty areas, that we may not need to train all those radiologists. Maybe we should be thinking differently. It's not just the caregivers. I mentioned the patient as part of the care team, but technology should be increasingly a part of that care team, and could be, I think, better used to fill some gaps. It's a lot more complicated in primary care, and hopefully we'll talk a little bit about that. But certainly in some of if you just think about anything with a pixel, like an image, AI does really well. I don't know how to say that in a nice way. Does a really good job reading things like pathology slides or retinal images. There has to be context and there has to be a human in the loop, but it is ways that you can either lower cognitive load, improve efficiency, and or target the highest risk cases to clinicians. And over time, as those models get better, more fair, more available, I think it's going to help improve some of the access to care, especially for specialty and diagnostic.
Just to stick with that a moment, I mean, what you're describing are relatively binary decisions. With chatbot and all this kind of stuff, will we be able to go and do decision support that is 10 levels more sophisticated than that? I mean, if we just stick with talking to specialties, because decision-making about cancers or decision-making, I mean, I have cataracts and I have Fuchs dystrophy, and I have about 3 or 4 other things going on with my eyes. So the decisions aren't binary. They're more complicated than that. Will these technologies in the near term be helpful here?
So let me emphasize again, like certainly philosophically for us, we see AI as a augmentation to clinical practice. There's an expression, and I don't know the origin of it, but I'll repeat it often, which is that AI won't replace doctors, but doctors who use AI will replace doctors who don't. It'll be the same for law, for nursing, for everything else. And especially, by the way, because we use AI in our everyday lives. Like when your phone autocompletes something, when you're typing something, that's AI. That's a language model. So we're already using it more ubiquitously than we've done in health because there are important safety issues and other complications. You're asking about kind of this next gen scalar leap of generative AI, which is basically large language models, which have taken a big technological leap in the last 6 to 9 months. I mean, it's pretty extraordinary. And whereas AI, some of the AI things I was mentioning do a thing. They read a prostate biopsy to figure out what's the Gleason grade, or they read the mammogram, or they read your retinal image. They're trained on a data set. They're made for a purpose. What we're moving into now is an era where technology has multiple use cases or has multiple purposes. So it's an ability of the model not to have to be trained on a specific data set to do a specific thing. It's trained on the world's knowledge. And I don't mean to be dramatic, but I want to be a little dramatic. It's trained on the world's knowledge. Now, it's also trained on all kinds of other things. It's not just facts. But has anybody in here used ChatGPT? Has anybody used, wait, raise your hand, I'm really curious to see what the age distribution is for, who's used it for a paper? No, you don't have to admit that. I used it to write a memo at work. I did chat, like it's a competing company, and I used it to write a memo at work. And who's used Bard yet? I know Lou has, because he just got it, but you haven't used it yet. Has anybody used Bard? That's one of the Google large language models that we just put out last week. It is. I was telling Chip earlier. It is all we can talk about in Silicon Valley is large language model. Like it's all that anyone can talk about, and it's the way they talk about it. The people who've been there a long time it's a scalar leap, like when the internet happened, when Al Gore invented the internet or whatever happened, when mobile phones came about, the smartphone, and now this. So we're so early in this, we don't actually know what it's going to be able to do. We have some sense of it, but we don't have any. If you think about back in 2007 when Apple phone came out, I don't think anybody could have imagined it would start revolutions, but it would also, cause people to commit suicide because of the things they saw on it, right? So there's this good and bad of what the technology can do. The large language models, like the medical one that we built and that we've published on at Google is, where's my medical students? All right, passed the USMLE with a score of 85%, and did that having passed it with a score of 67% in December. We trained it, published, it was able to pass with a score. Then we improved it that much in 2 months. It passes the Indian medical exam also, so it's English language right now. ChatGPT passes the bar exam. Like these are, and what's good about that in some ways is that it's getting better at fact, but it can also do some reasoning, and it can explain why it chose the answer, and in a way that feels almost human-like. And it can explain why other answers on the test were wrong. Now, it doesn't get everything right. It misses some contextual things. It definitely is not ready for prime time out in the real world, but it is, from a research standpoint, I think a really interesting opportunity to think about use cases like, is it helpful in medical education to help students learn why answers are right or wrong because it explains the things? Could it be helpful with adding to your differential diagnosis when you're seeing a complex patient or even a straightforward patient? Can it synthesize new literature on a topic so that it can help present it to you in a fashion that is easier than you trying to keep up with all the literature? Can it improve safety by saying, you know what, in every other patient like this, you prescribe this drug and not this drug, or I don't think you meant to prescribe 4 milligrams, we think you meant to prescribe 0.4 milligrams, right? So those are AI models can do some of all those things, but they can't do all of those things. And I think this is the part that we're in the Wild West of learning what's the potential. I'd say hopefully we'll get more questions about it because I'll just say right now, I think for the most part, certainly for us at Google, we don't think it's clinically facing because the risks are super high. But if you think about other use cases, like prior authorization or utilization management or bed management or maybe even answering basic questions that a call center would do. Those are some of the early kinds of use cases that our partners are interested in doing with us, and that's a similar story, I'd say, with Microsoft and others. But it's definitely to watch, and I'd say for the students, I just want to make sure that it's on y'all's radar, because many of you have mentioned it to me today. It's an incredibly exciting time for you all. It's an incredibly terrifying time for you all. I think we all need to sort out what are the clerical things that LLMs can do that that reduce cognitive burden and give clinicians of all kinds more time to think about patients, humanity, context, equity. But I think it's going to mean that we're going to have to not only learn about Medicaid, but we're going to have to learn the language of what is AI and what are the pros and cons and how do we think about it. It could do a lot of really great things, but I do think we're early, but it's going to accelerate, and that's why I just want to make sure that they're paying attention to it, and so are their faculty, because it may change the way that we take tests, give tests, accelerate training, and care for patients.
So let's come back down to earth.
Okay.
And there was a lot of discussion earlier about burnout.
Yeah.
And at least from some research and some people's point of view, the digitization may, not necessarily the miracles we're talking about here, but what happens actually right now with the records, actually may be one of contributors to burnout. It clearly, even with experience over time, has not necessarily helped workflow. Sometimes it's hurt workflow. How do you respond to what we do about that and how we think about that? Because one of the things we have to do is figure out ways to eliminate those factors that are contributing to actually making it more difficult for providers and clinicians to provide care than less, even though the compliance machine that we all live by requires all these things.
The compliance machine.
Yeah. And you're partly at fault for it, but
So let's start there. In fact, when I was national coordinator for Health IT, and so I was living in Washington at the time, and my husband came up to visit. He's an ER doc, and they had Meditech. That's the system they used at Lakeview Hospital, and he hated his electronic health record. I mean, like with so much passion. And we actually got into a fight in a restaurant in DC, like a James Carville, Mary Matlin kind of fight. Like we were yelling at each other. You know this. We were yelling we never fight. My husband and I, like we have this peaceful. But we got into a thing about EHRs, and the waiter came over to ask me if are you okay? And like it was a thing. It's like, no, he's not going to hurt me, but he might throw something on the ground that involves an EHR. So I was in my house while I was in DC. So I'm in DC trying to, push electronic health records on the country. And my own husband's like, what are you doing? You're ruining the practice of medicine. Well, I will say fast forward now. I was there until 17. And fast forward, he can't live without his EHR because he can check things after he's left the hospital. He can, find old notes. He's even gotten used to it. And now there's other things that irritate and bother him from the compliance machina. And rightly so. So I do think, Meditech aside, I think that most systems have improved. Meditech still needs a lot of help. And we're working with them at Google. I think we've created a user interface that's easier, and they're adopting that on top. So part of the problem with EHRs, Chip, was that we were forcing people to enter data, which, by the way, doctors were really good complainers about the EHR, but for years nurses suffered in silence. And I just want to call that out. The nursing documentation is a lot worse than physician documentation. And anyway, and nurses have better education about health IT in their curricula, so they're better able to handle it. Well, So I think but one of the early things that we were like, you document things in the system and it would just disappear. You'd never see it. You didn't know what was happening to it. It wasn't useful in any way at all. Well, 5 years even later, the data says, I mean, it's not just Karen says, the data says that people are using that data for population health, for individual level care. And it is also being used to inform things like artificial intelligence, to advance access to social determinants of health and get people access to other services. So it was very painful, but it's now bearing some fruit. I think what's different about things like AI and large language models, just to go back up here, is that they bear fruit like within seconds. And so I think that the turnaround cycle will feel really different this round, because now it's not entering the data, it's making the data sing. And that comes with good and with bad. But I think but the story about EHRs is that it was worth the investment. And I'm gonna say that would we have done it the same way again? No. I mean, for example, what happened with electronic health records is that there was the HITECH Act was part of a stimulus act, ARA. So there was this big push in Congress to get us out of the recession, throw money out. Part of that was throwing almost $40 billion to digitize the healthcare infrastructure. It was a time-bound spend. So the then national coordinator, David Blumenthal, had to figure out what's the fastest way I can spend that money. Okay, well, there's existing EHRs in the field. We'll use those. We're not going to require them to have the same standards. So we'll have a Tower of Babel where they don't talk to each other, but we've got to digitize. I know that they thought at the time that we would also have ACOs, so different healthcare systems would use different EHRs. It didn't matter if they'd talk, because patients would be captured and stay in their ACO, right? It was just a different way of thinking. And you got to remember too that HITECH Act passed just about exactly the same time as when the iPhone came on the market. So when you're writing that legislation for digitizing the American healthcare experience, you're living in a world of like peeling the shrink wrap off of a box and sticking a CD, might have been a floppy, I don't know, into the computer to download the software, and maybe the data stayed on-prem in a server. Then all of a sudden there's this a whole other world where everything happens on the phone, right? And now it's in the cloud. So now that we're in this place today, it would have been, like doing it today would have been a different exercise. We would have required harmonization of standards. We would have required APIs. We would have required that consumers had access to their data. It's just taken a long time to get to this level of maturation. It is, by the way, what public health can learn from and build on, because now it doesn't have to make those mistakes of a lack of interoperability because we funded systems that fundamentally couldn't talk but didn't expect them to talk. Until I became national coordinator, and then I made that a policy, and I required APIs. I just want to call that out.
So that then opens up another aspect. We were talking about, I guess, the decision support of the physician or the other clinician. Then there's this whole area around monitoring and sort of, in a sense, patient involvement by machines that's different. What's the effect is that going to have? Because it's probably only just beginning.
I think we're at a stage right now where it's just a bunch of noise and there's no signal. And it's kind of like when my patients would show up with the spiral-bound notebook with all of their sugars. I couldn't find the signal in it unless we spent time sitting through it. When they could bring me a spreadsheet, we could sort it or whatever, like search on things. When it was electronic, and I think we're going to take a next step, which is I'm going to have some quantified self. I'm going to have ambient sensing. I'm going to wear it. It's going to be on my phone. It's going to be on a mat when I stand up. Like, I mean, the VA does this like for 10 years, but we're finally all figuring it out. So there's all this ambient sensing that will tell about how's my weight, how's my blood pressure, what's my heart rate looking like, what's my blood glucose, and then finding the signal in the noise and figuring out who needs to see the signal. We've right now been saying all the noise, all the data has to go to the doctor, and haven't been smart about using AI or data analytics to say this is abnormal for this person in this context, and that's why the clinician needs to know about it, and figuring out who on the team would need to know about it. It's I think right now that disconnect is really frustrating for especially clinicians, but definitely patients. And that disconnect is also related to the fact that everyone's got we have too much of everything. So people who are like veterans who are self-monitoring when they're doing hospital at home or even primary care at home, they have too many devices that don't all talk. And so figuring out how those systems become interoperable or how you limit what is the sensing technology that you use. And I can't remember if you're going to ask me about this, so I'm going to throw this in right now. One of the things that we're thinking about, the world that we're evolving to, is this idea of a doctor in your pocket. So people do wear a lot of things and have sensors, but it turns out there's a lot of sensors on your smartphone that can do quite a bit, even independently. They're better, like for gait and falls and some other things if you have earbud in or a watch and a phone, but they're pretty good actually just as a phone. So the work that Apple does these things with AFib, we're doing very similar things. Our work on our Android is, can the smartphone be a stethoscope, do vital signs, do maternal ultrasound, diagnose a fracture. We just published another paper today about taking an external image of the eye, and it can diagnose hyperlipidemia, hypertension, and diabetes, as well as if you go to a health fair, by the way. The area under the curve is as good as if you are going to the health fair. These are self-care tools in the person's hand. It's also tools in the community health worker's hand or the doctor's hand. This is early stuff, like it's research, but if you think about having the phone, it's a portal for information, to find people like you on YouTube or to find information on search. It's a portal for telehealth. It's a way to store your own health data, and then it's potentially also a way to do some additional sensing. So I bet we're not alone in thinking like that. It's just like right now there's this cacophony of ways that people are sensing, and it's really confusing for people, but also for the clinicians. So how to kind of get that all in one place and handle the data before you hand it over to the care team is, I think, a next gen there.
There was also a lot of discussion earlier. We had a panel on social determinants, and there's so much in inequity that needs to be dealt with. Can the digitizing that we're talking about help us there in ways that we might not have envisioned yet?
It's one of the primary reasons that I went to this job, because I think that technology should eliminate disparities, but if you're not intentional, it'll exacerbate them. And there's a whole host of ways that happens. Sometimes it's really dangerous, like if you don't build a pulse ox that's inclusive and can read appropriate SpO2 on different skin tones, then Black people are more likely to be misdiagnosed and die from COVID. This paper in, was it JAMA? Mara will know. And like it's an example of how you have to build with intention a product that is going, like all the sensors that I mentioned, they have to be built with intentionality, that they work in different skin tones. They have to also it's not just about color of your skin, but it's also about things like cognitive load, language, abilities in other ways. So this is one really important responsibility that digital has with all the tools and technology, is just the functionality of it in the ecosystem. Second big bucket is the models. I'll call out AI. They're notoriously biased. They're predicate, and large language models will have the same issue. They're predicated on history, and history is predicated on a kind of racist system that is, no offense, but paternalistic. So it's got this point of view about the world, and they have a point of view about the world. I mean, you're not that you're paternalistic, but
I'm a white man.
Yes. And so this is really important work for us, that I have a whole equity team that does this across the company, which is how are we finding partners who are going to ask the right questions? How do we build the models so we weight them appropriately so they make sense for the application and for all the populations that we want to serve? This is going to be true with LLMs. There's a lot of fairness and bias issues, but and that's the second bucket. I'm going to mention a third bucket, which is just the availability. Just again, another reason I get excited about things like Doctor in Your Pocket, because Android is a very inexpensive type of phone. So it's not a premium product, and there's about 3 billion people on the planet who use an Android phone, and a lot of them are in low and middle income countries. So a whole lot of our work is thinking, what are the ways that that phone becomes useful to a community health volunteer in Kenya who needs to go out and help women who are pregnant, and that is a way that then that community health volunteer, this is a true story, doesn't have to carry around a bunch of logbooks, but can bring their Android phone and document. So it's increasing access not only to the care provision, but also in that case we've worked with the World Health Organization to create an open platform so they can build an app that brings the right evidence-based care right to that community health volunteer's hand and right to the person in front. We could spend a lot of time making tools that help higher end needs, but we would like to spend our time thinking about tools that are going to support a broader challenge in all populations. And I'm not trying to, I'm tooting our horn a little bit, but I think this is an example though of how sometimes we say, oh, smartphone, not everybody has that. People are going to have that in a few years' time, and already a lot of folks do. So we should start building for that future when you can do offline or cell and you don't have to have broadband, and that matters in rural America, but also in sub-Saharan Africa. And I think we've been a little fixed in a box about how we think of technology. We often want it to be, oh, it's going to cure cancer, oh, it's going to do the heart surgery for you. Those are important problems to solve, but the biggest problems the world has are metabolic disease, malignancy, maternal health, and mental health. Those are like what we call the 4Ms, that's Sustainable Development Goals. You can do a lot of good for global morbidity and mortality and improve health and address equity by thinking from kind of a population public health standpoint.
And you bring up public health, and maybe I'll ask one more question before I open it up. So coming through COVID, I think even those of us that have public health degrees and have a lot of respect for those who fought the battle of COVID from the front of the public health side, I think the politics and the funding, in some ways, public health is sort of in tatters across the country. Yeah. Can technology help public health recover and do what it's supposed to do in terms of the kinds of things you were just talking about and others, in terms of protecting us as a population rather than as individuals?
I think it's one of the important inputs. One of the things about high tech is that funding supported not only the software and the hardware, but also the workforce that needed to operate it and use it. So the High Tech Act had training built in, it did some curricular work, but also a lot of frontline training for clinicians. So when we think about technology supporting public health, I think we have to think about it in a similar holistic way. There's got to be people and data and structure and longer term financing. I'd say the public health community has actually done a really good job with this coming out of the pandemic, of thinking holistically about how you need a system that functions, not just technology that functions. But the technology is complicated, confusing, and expensive. And it's, I think, it's also got a kind of a commercial component to it, which gives public health hives. And I was a health commissioner. I'm just speaking truth because that's and now I'm on the commercial side. So I've seen both ends, but I think it's going to be some cultural evolution for public health to understand. I need to buy a cloud system, and it needs to be interoperable with other cloud systems. I need to know what fire tools are, and I need to know where I can find the fire tools on a workbench that whoever, ASTO, the health officers or association has developed, so that I can do e-case reporting or laboratory reporting or the other functionalities that I need to do. I don't need to build it all myself, but I need to be part of a bigger system. And those are all it's vocabulary and technology understanding for the incumbent workforce. That's a pretty big challenge. I don't know what Rachel said earlier, so hopefully she talked about the Admiral Lavin, but I don't know if she talked about public health. Did she? Is anybody here?
Yes, she did.
I love her, by the way. What's happened is the public and private sector, the CDC and the Office of National Coordinator, all the trade associations have come together, and there's a data modernization initiative that is very forward-leaning. It's the right thing to do. You can find it on the CDC website. There was actually just a letter of support going around yesterday from the epidemiologists and others to say to Congress, this is a good thing, we should keep doing it. So, and that thing is building on what we learned from what we did wrong in the healthcare system. So we need to start from standards that are harmonized and open and not proprietary. We need to have interoperable systems. We need to be in the cloud and not on-prem, just as not on in a server in a closet. Like all the things that they want to learn from and quickly accelerate. They've picked use cases like e-case reports and laboratory reporting that are very specific that allow them to start to move data on the public health highway. So I'm super optimistic about it. But they are going to need more funding and they're going to need help going forward. It's a big workforce challenge because a lot of the technology talent to support analytics and AI and running cloud systems are employed by tech, and they're financially out of reach for public health. Maybe an outcome of all the layoffs is they're less financially out of reach. You might want to do some public service for a while. I've actually been trying to encourage people in that direction and tell CDC same. But I think, so figuring out are there ways to do exchange programs or fellowships so that there's some training. There are a few report recommendations, and there's a few small programs at the CDC, but I think hopefully in that direction of maybe you don't need to buy all the data scientists, but you certainly need to find a way to partner. And I just, I think, and we did do this during the pandemic in a few ways. We Google plus Apple and Microsoft came together to create a tool for contact tracing that we did with the health departments. When we'd have the first conversation with the health department about we've made this API and it's interoperable, whether you use an Android phone or an iPhone, and it's just a tool for your toolbox. We're not going to collect the data. It goes into your system. It was like being in a middle school dance, and they were like on that side of the wall, and we were on this side of the wall, and nobody knew what to say to anybody. And I'd been a public health person, so I thought, oh, this would be great. I'll talk to... But there's so much distrust, I think, and I think that's going to be, I said that like from the commercial, the public health struggles to know what it's okay for it to do and talk about and partner with the private sector. And so I do hope we'll learn from some of those and build on the bridges from the pandemic, we the country, and be able to carry those forward to do more good things into the future. Because I know a lot of the tech companies are really interested in being helpful, but it's going to also, the door's going to have to be open. Like we can't just be there knocking.
Right. Well, why don't we open it up? I think you're on.
Yeah.
Thank you, Karen, for coming to speak. During COVID, I worked with the California Department of Public Health and SFDPH, San Francisco Department of Public Health, to build a chatbot that we use to prioritize contact tracing efforts on the most vulnerable populations. And I thought that was like a really wonderful use of using technology to solve some inequities. In my experience with that, though, the chatbot we built in English, and it came out in Spanish months later, and was never available in Chinese or Vietnamese or Filipino or Tagalog. It was, even though we were able to do it, to use it to support people with the most need, it was heavily dependent on the English language. Mm-hmm. And I think that with large language models like Bard being trained on English, that will, I'm concerned that people that don't speak English, and there's many of them in our country that, English is not the first language, will be left behind. Can you speak to that a little bit, and how can we ensure that people whose English is not their first language or don't speak English at all are not left behind as generative AI models that speak English take over?
This is a real challenge for us as a company, the language component, because we're a global company. And so, for example, more people speak Bengali in India than live in America. And we're present in that ecosystem, right? And it's not even the most common language spoken in India. So we're always thinking about language access and have, as you probably know, done a lot of work with AI to create translation models. Those are an early version of large language models because it's necessary for our products like search and YouTube and Maps, Play Store. So that's a part of our ethos. That getting these models mature so they're useful globally, I can't tell you how long it'll take because I just don't know. Because I'm not an AI researcher, but I told you all those numbers about how quickly some of my team, some of my docs, and some others were able to advance that model. It's pretty extraordinary. And you watch the horse race between us and Microsoft and how much they're advancing their model. I'd like to see language be incorporated for a few reasons, though. I mean, and I'll just sort of call out this one about bias, is that what's happening, is that the language models are being improved. So every time Lou uses Bard and corrects it, which we would encourage you to do, it's learning from that. It's learning from how you respond and interact. Well, it's going to have a lot of learning in this early cycle, both us and ChatGPT, from affluent people who speak English. And I think people on coasts, I find, it's all we can talk about in Silicon Valley. At dinner last night with friends, they're like, what are you talking about? Like, what I'm saying? And these are, it's, so I am also trying to be realistic that there's a narrow way that it's being that's being learned, that's learning on itself and trying to evolve, that has, I think, other implications for its trajectory, what it thinks is right. Do you see what I'm saying? So it's not even just about having it translatable, but how do we make sure that it's learning in a way that drives equity and that is thinking about context. So it's definitely on our minds, and it as a company, and I hope that we can solve some of that foundational stuff pretty soon so that it's more globally applicable. But as a business matter for us as a company, it's also really important. Like cloud, for example, we're all over the world, so we need to have large language models that APIs to those in our cloud product that work in Indonesia and Singapore and India, because so there's a commercial interest for all the cloud providers also to try to mature it, but I have no idea how long that will take. Maybe you guys will get smart in that area and learn. It's a really interesting problem to solve and important.
So I actually have a related question. There was this op-ed in the New York Times today from some of these developers about how these essentially represented...
Today's the day I didn't read the New York Times.
Yeah, so the idea was that these models almost represent an existential threat to humanity in some sense, and calling for a pause on the speed at which these are being rolled out. And I wonder, from your perspective, if the speed at which these models may be used in a clinical setting is concerning, and especially from the bias standpoint, like what sort of guardrails need to be in place before we're really pushing these forward?
So foundationally, I'll start. We have something called our AI principles, which I would encourage you to look up. And if you haven't read about Bard, so we'll see. We share the concern. I'll start there, and then I'll work backwards. I want to also say that Bard is one large language model we have that's consumer facing. We have this one called MedPalm, which is our medical. It's got also medical information in it. There are other large language models owned by companies large and small. So these aren't the only two in the world. They just happen to be the two getting the most attention, Bard and ChatGPT. Most of the uses for them, the release that we have now, for example, with Bard, it's not supposed to do health information. I asked it last night, what is diabetes, and it told me. It gave a very good answer, but it did not give a very good citation, a blue link of where to navigate. If you did that same question on regular search, it's going to bring you to the CDC. So that's an example of how it can answer the question. Now, it's not going to tell you what to take for diabetes or give you medical advice. We know that it can answer fact things, but it's not supposed to do the additional give advice because we don't think it's ready. And it goes back to these AI principles, like we want to do the things that are safe and that are going to be equitable, and there's ways that we want to start to release these things into the wild, but we at the same time need to start learning from them. And we'll do something similar with MedPalm. So that's our medical one, our company medical one, that has medical knowledge. And I know it didn't pass the nursing exam. So every time I say that aloud, I feel like it's so ridiculous. But I have mostly doctors that work for me, so that's a bias, right? It's not trained to pass the pharmacy exam or the medical exam. It's trained to pass the physician exam. But anyway, so it can answer questions. It can take the test really well. It can figure out. It can reason why it did that. And the question would be like, how far would you want to take that in terms of diagnostics and therapeutics? It could also do other things, like read and I'm saying this hypothetically because we don't have a product like this. This is stuff we're learning on. But it can read a medical record and synthesize it and present it in the way that maybe a medical student might do, reading an old chart. It could do that for utilization management or prior authorization. These are the kinds of things we're being asked to think about. They're not clinically facing. When I say think about, I mean by partners with whom we work with through cloud and other places, Stanford, Mayo, like academic partners we have. Hey, what if? There's all these potential use cases. We're leaning more as a company towards those that are not life or death or clinically facing. Can we do some things that are more clerically oriented and see how it performs? But a human has to go over the homework, which is also very labor intensive. And another reason that as we start to roll these out, we want to find partners who are aligned with our AI principles. So, okay, well, you won't want to do harm. You believe in equity. You want to make sure that the models are going to perform in a way that leads to better health outcomes, et cetera. It's not, there's no nefarious purpose. So we need to align with partners that want to make models for good. And we also need to think about how those partners are sufficiently representing diverse points of view and care for, let's call it diverse patients, enroll diverse patients. Because we also would want to be careful about not only picking very high-end academic organizations, right? You can see how very quickly the human in the loop becomes really important. Like the doc who's worked in, like Myra Kleinpeter's seen a bunch of different stuff than the cardiologist who's only got a half-day clinic a week at Harvard. Pick on them. Pick on Harvard. Yes? I'll go faster. I'm sorry.
I think beyond the clinical yes or no decisions that could have nefarious, results, there is like a Google. I'm seeing that you're trying to help with the end of the pandemic emergency by directing people to Medicaid resources, and that's I think a tool. Like we did work during the pandemic on how many people were signed up for Medicaid and never used the benefits because they didn't understand them. Or they didn't even know how to get it, or they had this misconception that physicians don't want to see Medicaid patients. So I think the AI could be useful there. The problem with that, however, is how are you going to get over regulatory hurdles from various state Medicaid agencies, and are you willing to test the software that you've built? Like, will you actually show us if it worked?
Let me just, we are using AI for this Medicaid work. So it's not a large language, really. It's kind of. It's like an early version. It's called Hummingbird. And it is the kind of thing we use to call a restaurant and see what hours they're open. We're using to call physicians in the U.S. to find out if they take Medicaid or what hours of operation or what languages they speak. So we've been building out a physician directory, and very intentionally been building it out to show federally qualified health centers and find providers that take public insurance. It's very easy to find providers who take Blue Cross, but it's harder to get a layer below. So we used AI, Hummingbird, to call and to build out a directory. And then we've built capability that people can find care near them and find care that takes Medicaid. And then in some cases, schedule an appointment online. That would be open to any provider that wanted to do it. It's a matter of onboarding and a longer technical story. But what we're doing there is curating an ecosystem. So we're saying, just like think about it like restaurants. That we're just curating all the restaurants that are out there and helping people find them and make it and arrange a table. It's not a commercial or proprietary tool, and it doesn't require regulation in that context because it's really just about information. And the more people want to share that help them on their health journey, the more we can do to help them find those resources. But we also knew the flip. It wasn't just find a doctor near me. It was what kind of insurance do I have, and then helping people know also about SNAP. We did something very similar in that space. That's an example of how we would try to lift up an issue that we think touches a lot of the population, has import because the information is a determinant of health, and then help people to navigate through the system. But it wouldn't, we don't schedule the appointment. We just help you find out where to schedule it and then open the door for you to do it. Does that answer your question?
So
Sort of, not really. All right, you can ask me later.
There were a lot of hands up, but I'm told we have time for one more question. So let me.
But I did so good. I only took 3 minutes answering that one.
Earlier, you talked about using some of the more advanced pieces of telemedicine for people in Africa. And my question was, we have 2 parishes in Louisiana that don't have any doctors. Is Google trying to find is open and available to working with smaller technology companies here to serve those same sort of people?
So for telehealth, the work that was, let's see, first of all, for the work in sub-Saharan Africa, it's less about telehealth and more about the phone as being either for sensing or a data layer. We haven't done specific things for telehealth in low resource environments like that. But we are looking at that same kind of idea of the sensing technology, using the phone as, can it be a stethoscope? Can it do maternal ultrasound in the U.S.? We haven't started anything, but we are interested to know if there's ways that we can be helpful in these ecosystems. We just have a lot of energy and interest from Bill and Melinda Gates Foundation and others with whom we work in other parts of the world, and there's just so much need. So we're open to it. We just don't have a specific place that we've been working. But I would say about the telehealth, this is an interesting way for you to think about how we see the world. We have made Google Meet HIPAA compliant. We applied for that during the pandemic, so that if you're just through a Google Meet, you don't need any other special platform or technology. The clinician can use that as the platform. Now, it doesn't have all the bells and whistles and opportunities maybe as some other do, but to make it as low cost and as straightforward and simple, and it's already in the clinician's hand. So we're definitely open to talking with folks about it. We're just right now in all those areas a little more focused in very low resource parts of the world. I know it's relative, I get it, but yeah.
All right, well, thank you both so much. We appreciate it.
Oh wait, can I tell a Chip Kahn story? Yes, I can, because my watch says I have 4 minutes. Sorry, Kevin. I'm holding up the alcohol. I met Chip Kahn in 2005, and I met him because a woman named Diane Rowland, who was at the Kaiser Family Foundation for a long time, who I had known, she said, oh, there's this guy, Chip Kahn, that you should talk to. This is right after Katrina. The whole place was a hot mess. And he's from New Orleans, and he wants to help. And so I had breakfast with Chip in D.C., his chapeau. He always wears a chapeau. And I was like, I don't know who this guy is and what's going on, but anybody that wants to help, I'm in. And you did. And you did a few things, one of which is introduced me to the people at Johnson & Johnson, who swooped in and actually gave me, I think it was a $125,000 check. I'd never seen anything like that in my life, to keep the Covenant House Clinic going. We had set up some makeshift clinics around town. And then that and a bunch of other help that J&J brought that we did with the state and other people led to us having this network of community health centers that we have in New Orleans, like Daughters and Access Health and the No AIDS Task Force and St. Thomas. It all sort of blossomed because Chip helped to make sure that we had resources and connections with the right people, including Newt Gingrich, actually, who helped us think about what is the long-term sustainable model for us to provide, to go into community and provide great primary care and mental health services for community. So I want to say thank you to Chip, because you've helped hundreds of thousands of people, and it's a real honor to be here with you today.
All right. Well, thank you all for coming. That concludes this portion where we do have a reception afterwards. And just a reminder to everybody that if you're interested, we have an event tomorrow where our panelists today are going to present their individual research projects. That's on the Uptown campus. Information on that is on the same site that the information for today's event was on. So we hope to see you there.